Hello everyone, I'm J.C. Kasky, Professor of Cardiovascular Science at St. George's University of London, and I'm delighted to be taking part in this educational program. Will comprise 3 modules on the management of chronic coronary syndromes. The first module will be based on managing chronic coronary syndromes in clinical practice, which are the challenges we have in terms of preventing disease and controlling symptoms. The ESC guidelines were modified in 2019 and they introduced very interesting changes. The first one is that rather than talking about stable angina or stable coronary artery disease, they talk about chronic coronary syndromes. And this is to emphasize the importance of different mechanisms of myocardial ischemia, not just obstructive coronary artery disease, but functional mechanisms as well. And they gave us 6 different clinical scenarios where you can see obstructive coronary artery disease, functional mechanisms involving the myocardium. So a more comprehensive way of dealing with angina pectoris or ischemic heart disease. The problem, however, is that the current paradigm for most cardiologists still is that angina pectoris means obstructive atherosclerotic epicardial coronary artery disease. This is for most cardiologists the cause of myocardial ischemia, and therefore diagnostic and therapeutic strategies for angina are largely determined by this paradigm. And it is not only physicians who feel like that, but also patients. Both see coronary artery stenosis as a mechanical problem that can be fixed by mechanical means, by dilating the coronary arteries. However, as we showed some years ago now, the causes of ischemic heart disease are many. Obstructive coronary artery disease is just one of the ends of the spectrum. And at the other end of the spectrum, we have coronary artery spasm. But in the middle, we have problems with the coronary microcirculation, which is able to cause angina exactly as coronary artery spasm or obstructive coronary artery disease can do. And microvascular dysfunction can appear in the form of structural abnormalities in the microvessels or functional problems like microvascular spasm or myocardial factors that can affect the function of the microvessels. So more complex in terms of mechanisms. And let's not forget that ischemic heart disease is also a continuum that involves obstructive coronary artery disease, but also the interaction with functional mechanisms. So obstructive coronary artery disease and microvascular dysfunction often coexist in a given individual. And this is important when it comes to identifying ways of treating ischemic heart disease. So the current situation, the current universe of angina pectoris ischemic heart disease involves coronary artery disease related angina, on the other end functional mechanisms like spasm, but in the middle you have a very, very large cohort of patients in whom microvascular abnormalities are responsible for the acute for the symptoms of ischemia. So the ESC guidelines have incorporated something else. They tell us of the importance of artery disease in OCA, ischemia with no obstructed coronary artery disease. And they give recommendations as how to identify these patients. So they say it is reasonable to do guidewire-based assessment of coronary flow reserve or microcirculatory resistance. You should or you could do intracoronary acetylcholine testing for coronary artery spasm and look for transthoracic Doppler of the LAD, etc., positron emission tomography to assess non-invasively coronary flow reserve. So they give importance now to these mechanisms. So let's discuss whether the goals of these guidelines have changed, and let's discuss how to manage anti-anginals. So the goals for the treatment of ischemic heart disease have not changed. We still want to prevent MI and death. We still want to reduce myocardial ischemia, and of course we want to improve symptoms and quality of life. And we have very effective strategies to improve clinical outcomes. We know that lifestyle changes are very important. Stop smoking, the use of statins, the use of ACE inhibitors or ARBs, antithrombotic therapy in the acute coronary syndrome, beta blockers in heart failure patients, and lately the use of LGP1 receptor agonists and SGLT2 inhibitors in diabetes mellitus have shown that these interventions can improve outcomes. And regarding the management of symptoms, the guidelines say, well, the initial choice of anti-anginal drugs depends on the individual patient's profile, the comorbidities, the drug interactions, the other therapies that are being administered, and also the patient preference. When the patients know what are the side effects of the drugs that are going to be prescribed. And they have modified their approach. Now they don't talk about first, second, and third line of treatment. They say, well, if you are going to give standard therapy, we have 3 steps. Beta blockers or calcium channel blockers. Then second step will be to add a calcium channel blocker to a beta blocker. And then if that doesn't work, then you add some of the newer drugs or second line drugs like nicorandil, ranolazine, or trimetazidine, and I'll come back to this in a minute. However, if you have somebody with high heart rate, you will have to choose drugs that slow down the heart rate. If your the patient's heart rate is low, you would like not to make things worse, so you are not going to use drugs that slow down the heart. You rather go for drugs that have no effect on the heart rate. And likewise, if the blood pressure is low, you would like to avoid medications that make the condition worse. So a slightly different approach, in the sense that they say, well, let's look for drugs that actually do what we want them to do in the individual patient. That's why now, for example, drugs like vasodilators like nicorandil or ranolazine, metabolic modulators and drugs who have a completely different mechanism and does not affect hemodynamics, appear now in the guidelines with a recommendation which is set to A. Now, I still have a few problems with the current guidelines recommendations. Although they are a lot better than in the previous guidelines, they don't really articulate the fact that there is no difference in efficacy when you compare anti-anginal agents. What they call first, second, and third line of treatment is not such a thing, because the evidence for the anti-anginal effect of the anti-anginals we have is not better for one or other in the clinical situation. And on the contrary, for the newer drugs like Ranola Leads, the evidence base for the use of these drugs is a lot better than the evidence we have for beta blockers or calcium channel blockers, or even nitrates. And the other problem with the guidelines is that they do not suggest individualizing patient treatment, except for a few things like heart rate or blood pressure or heart failure. So let's see, how can we apply the guidelines to a real life case. This is a 56-year-old British female CCU nurse who has a 2-year history of central chest pain and dyspnea on exertion, and occasionally also some chest discomfort at rest. The symptoms were getting more frequent. She was completely healthy until 2 years previously. She used to exercise, she used to cycle to work, she used to go for long journeys on her bike during the weekends. She was a little bit overweight. She had menopausal symptoms for 3 or 4 years. She was mildly hypertensive when seen in clinic. The total cholesterol, when first seen at the local hospital, was slightly raised, like her triglycerides. Her vitamin D levels were low. She had borderline HbA1c with a slightly raised high sensitivity CRP. She never smoked, but there was a very strong family history of diabetes mellitus and coronary artery disease. The rest of the systems were okay. Her baseline 12-lead ECG was normal. The baseline echocardiogram again showed no abnormalities, and importantly, there was no pulmonary hypertension, because we were worried about pulmonary hypertension because of the dyspnea. The exercise stress test was positive with ST segment depression at around 9 minutes, with a very good heart rate and slightly raised blood pressure. And she developed the usual symptoms, chest tightness and shortness of breath. So she went for an angiogram. The angiogram showed no obstructive coronary artery disease. She was reassured and started on sublingual GTN and bisoprolol, vitamin D supplementation, diet, regular exercise, and she was given an appointment in clinic 6 months later. When she came back to clinic 6 months later, there had been further deterioration of the symptoms despite the conventional treatment for angina. She had weekly episodes of rest angina now, mainly at night and in the early morning hours, with shortness of breath and chest tightness when she was walking, even on the flat now. And just by chance, when she was in clinic, she developed a spontaneous episode of chest pain. An ECG was taken, and there were ischemic changes on the ECG in the precordial leads. There was no cardiac troponin elevation, and the administration of GTN resolved the pain and the ST segment changes. So she was sent for an angiogram. with the possible diagnosis of microvascular angina, because the arteries were normal on the previous angiogram, coronary artery spasm, whether epicardial or microvascular because of the angina at rest and nocturnal angina. There was also the possibility of plaque disruption and thrombosis, which may occur, or coronary dissection in a woman with those symptoms at rest. The tests that were planned was a stress echocardiogram, a cardiac MRI perfusion scan, and angiography with acetylcholine provocation for spasm and physiology tests, exactly as the guidelines recommend. The idea was that we wanted to know the anatomy, we wanted to see if there was myocardial ischemia, we want to see whether the ischemia caused LV dysfunction, and above all, we wanted to know the mechanism of ischemia to select the right treatment. So the arteries were still normal, there was no obstruction. When we injected acetylcholine, there was no spasm in the epicardial arteries, but the patient developed the usual chest pain and ST segment changes similar to the ones we saw in clinic. The administration of nitrates resolved the pain and the electrocardiographic changes. And this is a typical example of microvascular spasm. But in addition, and I think this is what caused her angina at rest, she did have a reduced flow reserve, which was assessed in the catheter lab with adenosine. And the flow reserve was reduced to 1.6 for a normal of up to 3, of a normal of 3. The cardiac MRI perfusion scan showed the presence of subendocardial hypoperfusion, which is compatible with coronary microvascular dysfunction. So these tests allowed us to make a proper diagnosis of the problem. So she was treated with anti-spasm treatment, amlodipine, 10 milligrams daily, in addition to the other medications that she had been given previously. At 3 months follow-up, the rest angina had gone away, but she continued to have very bad effort-induced angina despite good control of her hemodynamic situation. So because of the microvascular dysfunction seen at angiography and which was not resolved by the calcium channel blockers, we prescribed Ranola Leads, started with 375 milligrams twice daily, and then up titrated this to 500 and later to 750 milligrams twice daily. And we did this because of the evidence we have in the literature for Ranola Leads in patients with microvascular dysfunction, which I'm actually showing you on this slide on the yellow boxes. And when we reviewed her at 3 months, her exercise capacity was a lot better. He had restarted cycling and she only had occasional chest pain on effort at high workload, and her HbA1c was also slightly improved. So I think that this case shows that we need to assess the characteristics of the patient, the characteristics of the angina, and then investigate the mechanisms responsive for ischemia if we want to give rational therapy. So we address both goals of treatment. We look for things that improve outcome, but also for drugs that improve symptoms. We selected pharmacological agents that specifically tackled the pathogenic mechanism we wanted to affect. In other words, we use a personalized approach to managing this patient. We consider the patient characteristics, the drugs that she was taking, and in this case, what the guidelines tell us in relation to a drug, say for example that some drugs are first line or second line, for us a second line recommended guideline like ranolazine was first line to treat the microvascular dysfunction in this patient. So I leave you with this figure that I will actually discuss later in the second and third modules from a paper we have recently published in The Lancet with Bill Bowden, showing the importance of identifying the causal mechanism, the pathophysiology of angina to treat patients. Look at the mechanism and give the right medications to the individual patient. Thank you very much.